Today we're going to take a look at intravenous guidelines for the adult patient at QHC. There's a certification process that we go through that's listed on the page in front of you. We've had to revise a little bit because of the current climate, so we're going to show you the video. There's going to be a link to the manual that'll be provided by HR. And then when you get to the floor, we're going to have you demonstrate to your practice specialist for that unit your technique. Based on that, we're also going to have a video that will show you technique. So what we look at QHC is we have RNs, RPNs, and MRTs. Those are technicians in DI that are capable of initiating a peripheral vascular access device. We do IV therapy for certain reasons. They're listed there. Quite often it's to give medication, maybe to maintain fluid balance. Clinical assessment's very important when you're looking at your patient. You want to take a look at the presence of edema, chest sounds. We don't want to fluid overload someone. Mentation is very important. If we have a patient that's a little bit cognitively impaired, we may want to have someone there with us to help to maybe stabilize the arm where we're going to start the IV initiation. You never know with patients, they can pull their arm back, they can act in ways that you don't expect, and it is possible to cause injury to the healthcare provider and the patient themselves if we don't have extra help with patients we think might present an issue. Overall, what we're trying to do is when we're initiating an IV, we're doing a lot of assessment. We want to minimize the chance for complications. There's an old saying in carpentry, measure twice, cut once. That's exactly what we're going to do. We're going to spend more time getting prepared for this than we are probably on the actual skill itself. So there's a list here of reasons why someone might get intravenous therapy. The vein criterion. So we're gonna palpate for a vein. One thing new research has shown, I think it's listed later on in the presentation, you want to stay at least 5 centimeters off the wrist if you're using a cephalic vein. There have been cases reported of ulnar nerve damage, so we want to try to avoid that. We also want to look at the patient's skin. If there's a lot of bruising, if there's areas where the veins are very knotted, or kind of areas that look like there's lots of twists and turns and that, we're going to try to pick an area, a vein that's relatively straight that we can go into. So veins of the hand. So what we generally do is we go distal to proximal when you're looking for a vein. So you're going to start at the hands. You're going to work your way up. One of the main considerations that you're going to have is that you want to know that depending on what therapy the person's having is where you're going to actually do it. So you want to take a look at, say, a patient that's in for short-term, maybe endoscopy, or they're in for just an x-ray and they need to get something. You could look at the veins of the hand, sort of work your way up. If you know it's a patient who's going to be admitted to the hospital, you might want to look at an area where there's no real flexion. I'd avoid the antecubital if you can. I've always preferred the cephalic vein for admitted patients, but then again, it's personal choice. But you want to make sure you're at least 5 centimeters off of the wrist if you use cephalic. Veins of the arm, those are here. I know a favorite of Emerge for short term is the antecubital. The issue when somebody comes to the floor is that that's also an area of flexion, and it can beep quite a bit. It interrupts the administration of fluids. So site selection, I mentioned you start at the most distal. You want to look at the non-dominant hand because you want the person to be able to move their dominant hand. You're going to palpate, make sure it's not pulsing. That's an artery. We don't want that. And then the bottom here again, choose the vein that's most appropriate to the therapy being provided. You want to avoid areas painful to palpation, areas of flexion, bruising. If someone has maybe a mastectomy or a dialysis shunt, you want to avoid that side, and definitely stay 5 centimeters off the wrist. I know I've emphasized that a lot, but there have been reported cases of ulnar nerve damage. It's distension of the vein. This can be tricky. Sometimes our patients come in, they're dehydrated. What you might want to do is just, I found probably the best way is just have the arm dangle over the side of the bed or the side of the stretcher. Just allows blood to flow that way. There are some other tricks. What I don't recommend is tapping. If you tap gently, you should be able to hear it. If you can hear it like that, that's way too hard. You don't want to do that. You also kind of want to anchor the vein. The tourniquet, usually you put at least 4 inches above where you're going to work. So I guess that would be 10 centimeters in metric terms. Complications of IV therapy, there's lots of them. Phlebitis, you can have infiltration. The fluid can go into the skin. Fluid overload, when you have a patient who's maybe a CHF patient who's at risk for that. We're giving them too much fluid. We're going to get the crackles in that when we auscultate. Speed shock, if we're giving something, a foreign body, and we're giving it too fast, we can create this reaction in the body, speed shock. The site can become infected, and we could also have an embolism. So there's lots of different complications that could happen. So if chemical phlebitis or chemical complication, inflammation of the vein, pain and tenderness, erythema, so that redness at or beyond the tip. So you want to remove it, remove the IV, you want to provide comfort measures, dilute meds when feasible. Mechanical complications, so again, we're going to look at that. It might be, the other thing is to your selection of the size. So our cannulas typically come, and we have a 20, a 22 gauge. The higher the number, the smaller the needle. 18s or 16s are often used in Emerge. Those are for larger vessels, and typically they're delivering a lot more fluid, maybe in the case of resuscitation or something. So infiltration, the fluid gets in the outlying skin. Can be particularly dangerous with certain types of drugs, like if somebody's having chemotherapy. The chemo drugs can be very caustic. Extravasation, so this is infiltration of a vesicant, and that's where I mentioned the chemo drugs can be really bad. Fluid overload, so I have the symptoms here. You're going to increase the blood pressure, dilation of neck veins, shortness of breath, tachypnea. So what's happening there is the patient just can't tolerate the volume, and that's one of the things I mentioned, like you have to know the patient before you're starting the IV therapy. A CHF patient would be at very high risk for fluid overload. Speed shock, so again, that's where you give a foreign substance and it's infused too quickly. Thrombosis, the formation of a blood clot within a blood vessel. Infection, so you can look for the redness, the pain, the purulent discharge, fever, all those things. Usually it's caused by a break in aseptic technique. So we want to make sure when we're doing this IV initiation that we're aseptic when we do it. Part of that, you'll see in the video, is always wear gloves. I know we're in an age right now where we're very concerned with PPE, but we should always be concerned with PPE. And the thing with patient bodily fluids, we have to protect ourselves because we don't even know what the next thing could be. So we want to make sure we're always, when we're handling fluids, we always have our gloves on. One trick is we have usually the common white gloves on the floor. If you have difficulty with those, they have the blue nitrile gloves. They're a little bit harder to find, but they do allow for better palpation. They're a little more tactile, and it's far better than not wearing gloves. The dressing site, so basically what it does, it protects protects your IV. We change our dressings and our nasal cannula, or pardon me, not nasal, our peripheral IVs, we change them every 96 hours at QHC. There is some research coming out now that's talking about leaving them in as long as they're patent, but our agency policy is we leave them in for 96 hours. Sterile lock maintenance, so basically you want to make sure that the lock is patent. And generally we flush our locks twice a day, our saline locks. Documentation, so here's a typical documentation screen that you would use for IV maintenance, and this will be part of your EDOC training too. This next screen is for if you're infusing something. So right now we have normal saline up here. It could be something else, but this is where you do the documentation of the infusion. Some little bit additional information. Use only normal or sodium chloride 0.9% when you're doing a blood transfusion. It's the only thing that's isotonic that's compatible with blood. The tourniquet can be left on for up to 2 minutes. Typically when you get your flash, you're going to release the tourniquet. Signs of fluid overload would be crackles in the lungs, shortness of breath, tachypnea. Again, avoid areas of inflection. The PVADs can stay in place for up to 96 hours. And insertion sites should be checked every hour. Okay, thank you very much.